Good afternoon, everyone, and welcome. My name is Emma Mertens. I'm the Program Manager of Community Relations at IDF, and I would like to welcome you to the session, Post-Transplant Late Effects in Patients with SCID. Before we begin, I'd like to give a brief disclaimer. Immune Deficiency Foundation, IDF, education events offer a wide array of educational presentations, including presentations developed by healthcare and life management professionals invited to serve as speakers. The views and opinions expressed by guest speakers do not necessarily reflect the views and opinions of IDF. The information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during the event. At this time, please join me in welcoming our presenter, Dr. Jennifer Heimall from the Children's Hospital of Philadelphia.
Hi, everybody. I'm really excited to be with you today to talk about late effects after treatment for severe combined immunodeficiency. So I wanted to thank Emma and the team for the kind invitation to speak with all of you today and to talk a little bit about what's been published and what we need to be humble. There's still so much for us to learn about what is coming as we have more and more children who are fortunately diagnosed by newborn screening. What we know now about late effects may change. So what I hope to do in the course of the next hour is outline the late concerns for post-transplant in all transplant patients, go into some SCID specific late effects, some of which are related to having primary immunodeficiency and having gotten bone marrow transplant, and some are more related back to the SCID specific genotypes. And then I also wanted to touch on the importance of, for patients who didn't have a definitive diagnosis prior to their transplant, what the role is and how to go about genetic testing after transplant. So to give a brief early history of transplant, the beginning, the birth of using bone marrow transplant to treat disease really did start with primary immunodeficiencies back in 1968. It was piloted with 3 children who had 2 of them had SCID and 1 had Wiskott-Aldrich syndrome, and they were fortunate to have HLA matched siblings. And what you can see is that as we go through time, we've learned how to use different medications to successfully condition and improve the uptake of the graft. And we've learned to use different techniques to manipulate the graft to reduce side effects like graft versus host disease. And we've learned to use alternative donor sources so that we can treat more and more patients who have hematopoietic stem cell abnormalities effectively with hematopoietic stem cell transplant. And you can see that, over the time period from 1968 to the start of the new century, there were really pretty steady improvements in survival for all patients being treated with transplant. But what couldn't be studied at that time and is definitely more of a growing area of active research are what are the late effects that we see in post-transplant. We know that in general, if patients are alive and generally well at 2 to 5 years after transplant, that their subsequent 10-year survival is also very good. But we also know that the data in young adult and pediatric post-transplant patients is very limited. And in most cases, the biggest body of data is coming from patients who receive their transplant for a malignancy-based indication. But with all those caveats, we see, late effects that can really impact almost any body system, from neuropsychologic late effects, pulmonary disease, renal disease, iron overload from transfusion burden, which is fortunately less of an issue for our patients, bone and growth abnormalities, development of endocrine issues, concern for infectious disease, either from pre-existing infections or development of infection in the post-transplant time period. The use of conditioning in particular leads us to need to study better concerns about gonadal dysfunction and infertility. Patients may have challenges with liver disease, cardiovascular disease, or secondary neoplasms or solid cancers. Again, all of these late effects, the reporting on them has primarily been done in people who received their transplant for malignancy. And what are some of the things that may impact on which of these different late effects you see are things such as the quality of immune function that's developed, the underlying development of SCID patients, what comorbidities were present prior to transplant and in the immediate post-transplant period, and what conditioning, if any, was used in preparation for the transplant. We think that in general, the prior infections and chemo and conditioning are thought to be probably particularly relevant for the transplant, the transplant group for SCID patients. Another very obvious thing to be concerned about is the risk of graft versus host disease having developed in these patients. So we know that graft versus host disease occurs still in about 20% of SCID patients. If we only look at chronic graft versus host disease, so graft versus host disease that persists beyond the immediate, few months post-transplant, that is less common. But we also know that the medications that are used to treat graft versus host disease and to try to prophylax against graft versus host disease can affect on the thymic microenvironment. And because we know the thymus is so important for T-cell development, this is a particular concern for severe combined immunodeficiency patients, where our main indication for doing the transplant to begin with was to have effective T-cell reconstitution. So when we talk with families in the pre-transplant time point about what are the risks, I think the things that we really need to focus on are, this is a transplant that's being performed during infancy, and that is still a relatively rare thing to have happen. It's not very common that for a malignant indication, we would be doing a transplant in the first, ideally the first 3 months of life, but in severe combined immunodeficiency, this is our goal. Our goal is to try to have the transplant completed, within the first 3, at most 4 months to life, to try to minimize the risk of developing infection before transplant, which we know has its obvious impact on survival, because it's harder to fight off infection. When we are following these patients over time, we need to consider the durability of the immune reconstitution that's achieved. And we have to think about how that might be different based on the type of graft that was used, the type of conditioning. So was the conditioning that was used just serotherapy or just immunosuppression? Or did patients receive a reduced intensity conditioning or RIC-based conditioning? Or did a patient receive a myeloablative conditioning regimen, which may be associated with better immune reconstitution, but then does it have more risk for some of these non-immune system organ late effects? We also need to think about what is the impact of the genotype of SCID on the non-immune organs. So we know that transplant is very effective to cure the immunologic aspect of disease, but it's very important that families and that patients, as they become older, are counseled that there is still an ability to pass on the genetic variants that cause SCID for the patient to future generations, because we haven't replaced every cell in the body. We only replace the immune system with a transplant. We also want to think about, when we are looking at the survival data and we're looking at the late effect data, how was SCID defined? We see similar survival for patients who were transplanted for classic versus hypomorphic or leaky SCID or Omen syndrome. But what we focus so much on survival, we haven't necessarily focused as much in looking at beyond survival. So what are there differences in those two subpopulations in terms of their neurologic outcomes? Are there differences in those two subpopulations in terms of their pulmonary outcomes? And then similarly, what do we know about outcomes beyond survival in patients with X-linked SCID versus RAG1 or RAG2 associated SCID, et cetera? Or even more simply, patients who had presented with T negative, B negative, NK positive SCID versus that might be more like a RAG genotype associated phenotype versus a patient who presents with T negative, B positive, NK negative SCID. As a for instance, we are starting to be able to understand that there are some differences by genotype that we see in the different clinical presentation and genotype presentation. So back in 2009, our European colleagues published a nice case cohort study looking at just over 100 patients who were at least 5 years out from transplant. And they looked at what features were associated, unfortunately, with risk of late death. And so I'm going to walk you through what they saw in this cohort. So each asterisk that you see on this slide represents a patient who passed away more than 5 years out from their transplant. And when they looked at those patients, the features that they saw, while in the overall cohort, there were about 18 patients who had a need for persistent nutritional support, there were 6 of the total 7 who died had a need for persistent nutritional support. Having difficulty with persistent graft versus host disease, 2 out of the 7 had difficulty with persistent chronic graft versus host disease. The presence of autoimmune or autoinflammatory complications was seen in 12 from the cohort overall. But you can see that the majority of those who did not have who passed away had some autoimmune or inflammatory complication, which speaks to their likely dysregulated immune response and perhaps a suboptimal immune reconstitution. There were also, of the patients who passed away, 5 of them had experienced growth failure, and 1, in addition to having those autoimmune and autoinflammatory complications that were flags that the immune reconstitution was not robust, 1 patient had experienced all of these symptoms, as well as also experiencing opportunistic infections, so surely a sign of a less than robust immune response. In addition, there were not deaths seen in this cohort, but difficulty with severe HPV or warts were seen, and difficulty with just infections in general, but not including HPV or opportunistic infections were also seen in a significant subportion of this kind of late effect cohort. And then a little bit later, 2 years later, Dr. Buckley from Duke published data looking at her cohort of patients who were transplanted, some of them, nearly 30 years out from transplant at that 2010 time point. And what she was able to report taking all of her post-transplant patients is that at a median of 8.6 years, the survival for patients transplanted for SCID was about 77%, and 86% of the patients were thought to be healthy by their family. And this, I'll come back to this, but this, the importance of the family and the patient's perception of what their health is and how the transplant has been effective for them or not is also something that we need to be cognizant of and study and understand and make sure that we're setting realistic expectations for families. So in her cohort, the majority thought that that the post-transplant patient was healthy, but then when she looked, more than half of them were identified to have had some sort of clinical problem, and I will speak more about that. In PIDTC data published in 2018, looking at T-cell reconstitution and looking at differences in immune reconstitution by genotype, this was a study from 44 centers across North America, looking retrospectively at patients who were transplanted from the 1980s up until 2012. What the PIDTC was able to demonstrate is that overall, the patients with RAG did have a more of an impairment in their T-cell reconstitution compared to patients who were transplanted for other genotypes. But the survival difference was really more seen in terms of patients who received transplant in this cohort for Artemis or DC LRE1C compared to any of the other genotypes. And the other thing that this study demonstrated nicely was that at 2 to 5 years post-transplant, when we get back to that, looking at what was the donor source, unrelated donors, use of an unrelated donor was associated with improved T-cell reconstitution. Use of conditioning, either reduced intensity or myeloablative conditioning, was associated with having better T-cell and B-cell reconstitution. And as expected, patients who had had significant difficulty with chronic graft versus host disease were found to have worse T and B-cell reconstitution than those who did not have difficulty with chronic graft versus host disease. This study also did a landmark analysis to say, hey, are there factors that we can look at early on post-transplant that are going to be associated with better late survival in terms of immune reconstitution? And in that case, from the same study, what was found was that having a CD4 count that was over 500 when a patient was at 6 months post-transplant was associated with improved survival. Similarly, having more than 200 naive T cells was associated with better immune reconstitution and better survival. Going back now to Dr. Buckley's data that I had alluded to. So what were those late effects that she saw in these patients that may have been related to impairment in immune reconstitution or may have been related to other factors that we still don't know? And what she found were that some of the most common complications that were seen were patients continuing to need immunoglobulin replacement. This was seen in over 50% of the cohort. There were a significant number of patients who had required booster transplant, significant needing standing antibiotics or having difficulty with persistent rashes. And then up to 20% still having difficulty with chronic sinusitis in the past 2 years since she was seeing them. And you'll recall from that previous slide, some of these patients were followed, even though the median was 8.7 years, some of them were up to 30 years out post-transplant. And you can see that there were many other commonly seen late effects, but they were relatively less than these 5 that were here. I think the other thing that was very interesting from this data to point out is that the timing of transplant impacted on the prevalence of seeing late effect. So there was a significant improvement in terms of risk of needing a booster transplant and having difficulty with growth in patients who were transplanted at a younger age. And there was a protective benefit in terms of both survival and having no medical problems by the assessment of a clinician in patients who were transplanted under 3.5 months of age. But interestingly, in the eye of the family and the perception of the family, which is really important, the timing of transplant didn't necessarily impact a difference there. So I think this is a really interesting slide and really shows the diversity of some of the late effects that have been reported, at least in that very large cohort from Duke. Now moving on to some more specific late effects that are perhaps a bit more unique to severe combined immunodeficiency. I had mentioned a couple slides ago that the European group noticed that there was difficulty with warts. This has been reported. It is most commonly seen in patients with IL-2RG or JAK3 and some IL-7 receptor associated SCID patients with SCID. It does not seem to correlate with the number of NK cells or the level of NK cell engraftment. But these warts can really be very recalcitrant to therapy. They can certainly impact on quality of life, and we worry about them in terms of their risk of developing secondary cancers, in particular squamous cell carcinoma. And this is a photo from one of our patients at CHOP who developed, this whole plane is severe warts, and these developed about 7 years post-transplant. And this is usually a very late effect. So you don't see this early on, it happens quite a few years out. Another important area to be aware of is the impact on growth. Again, going back to that slide from the European group, patients who had growth arrest and poor growth, that's where there was a concentration of patients who unfortunately did not survive well. Additionally, what has been described particularly by Dr. Cohen and the UCSF group in collaboration with Dr. Jennery from the UK, is that patients with radiosensitive forms of severe combined immunodeficiency, if they're exposed to alkylators, have significantly worse long-term growth than patients with a RAG-based severe combined immunodeficiency. And this is an important comparison to make because both of these genetic forms of severe combined immunodeficiency, when they present as having a lack of T cells, a lack of B cells, and NK cells are present. And it's not unless you do the genetic testing that you can differentiate a patient with radiosensitive forms of SCID compared to the RAG form of SCID, RAG1 or RAG2 forms of SCID that do not have the same radiation sensitivity. This difference has been described not just in patients with Artemis-associated SCID, but also these other genotypes as well. And it's seen both in girls and in boys. In terms of neurologic outcomes, this is an area of particular interest. I think it's very important, and the IDF also, I know, thinks it's very important. They have partnered with the Primary Immune Deficiency Foundation to launch a study to specifically do a cross-sectional assessment of patients who are at least 5 years out from having received transplant in the modern era to kind of objectively assess where they are in terms of neurologic and neurocognitive outcomes. But from data that's already been published, what we do know is that what has been more commonly seen relatively in patients with ADA SCID are challenges with greater levels of ADHD as compared to other forms of severe combined immunodeficiency, greater risk of learning impairment, and greater risk of hearing impairment. This hearing impairment is also seen in patients who are treated with transplant for reticular dysgenesis, which is sometimes considered a SCID condition, but is actually due to a different mechanism and impacts not T cells and B cells alone, but also neutrophils, and so has even more immunologic involvement. To date, there has not been reported neurocognitive impairment associated with these other genotypes, but this is something that in this upcoming study, we hope to be able to look at more carefully, because we will recruit patients across the PIDTC. And so there's a much broader range of genotypes, within that study population. And then another neurologic outcome that unfortunately is relatively common as a complication of congenital or peri-transplant CMV is CMV retinitis leading to blindness. That's unfortunate, and we hope that that can be improved by our studies to better understand the pathogenesis of how congenital CMV is transmitted and what sort of prophylaxis or preventative therapies we might be able to do in terms of early interventions to try to avoid severe and overwhelming CMV infections, because even in the era of newborn screening, one of the most common infections we see is congenital CMV. Moving on to dental implications in terms of late effect. While abnormal dentition is seen in more than 50% of all pediatric transplant survivors, and oral pain and dryness and hyperkeratosis are all seen with chronic graft versus host disease. So these are general transplant concerns. We also have appreciated that patients with those same radiosensitive forms of severe combined immunodeficiency are at increased risk of having later dental anomalies, including partial or even complete absence of their secondary dentition following use of alkylators for transplant in infancy. I wanted to spend a little bit of time going through work that was done in partnership with the Immune Deficiency Foundation and really spearheaded by Heather Smith from the SCID Angels. This data was very recently published in Clinical Immunology, and the IDF and SCID Angels have partnered to make this paper available to all for free. But what was done in this study was it was a survey, and what we report on here are 105 patients who were alive at 2 years post-transplant, and what their self-report is of their late medical complications, as well as what their recollection is of the counseling that they were given before a transplant. Because what we wanted to understand with this study is, does the patient perception of what they should think about, or what they should be able to expect based on the counseling from their providing doctor, does that match with what the patient later experiences? And so what we can see here is, so that we asked patients, did they recall being counseled that treatment would lead to cure? Yes, no, or not sure. And we understand that to different people, cure means different things. And I would really encourage you to read the paper, because I'm just showing a few snippets from it, but Heather and the IDF did really great work looking at this from a lot of different angles. And you can see that, almost greater than a third of the patients reported no health challenges. But the remaining patients did have difficulty with declining immune function, slow growth, pulmonary issues, recurrent sinusitis, those warts that we've mentioned, and difficulty with graft versus host disease. And so while they didn't comprise the majority, there were some patients who experienced more than one of these late effects. And there were some patients, as you can see indicated in blue, who were counseled that treatment would lead to cure. And the question is, did they perceive that these elements would still be present even if there was cure? In this same study, we also looked at what were the ongoing treatment needs for these patients. And so this is looking at patients in terms of whether they still had need for IVIG, whether they still had need for antibiotic prophylaxis or immunoglobulin replacement, patients who still needed viral or fungal prophylaxis, or patients who still required frequent antibiotics for infection. And again, that in the context of what their expected outcome would be based on what their recollection of counseling was. So back, a few years ago at this point, I think this paper we published about 5 years ago, I think, we took what exists, which is limited, about the data of late effects for patients who received a hematopoietic stem cell transplant for severe combined immunodeficiency, and use that to create guidelines and recommendations for what the long-term screening and management of patients should be. And we really tried to focus quite a bit in this report on the importance of reassessment of the immune system. And part of this is because we know many patients are followed closely by the transplant team and potentially their immunology team as well, but only to a certain point post-transplant. And every center is slightly different. Some centers may follow for 3 years post-transplant, some may follow for 5 years, but at some point, most transplant programs will graduate their patients from being followed by the transplant team per se to then being followed by an oncology survivorship group to look for late effects that are known to be, associated with having exposure to chemotherapy, that are known to be associated with having a bone marrow transplant. But those groups may not be thinking through the lens of immunology and thinking through the lens of transplant for this non-malignant primary immunodeficiency indication. And so we wanted to really emphasize that it's important for these elements of the immune reconstitution to be evaluated serially over time, certainly starting no later than 3 months after transplant, but then continued lifelong to make sure we're constantly checking on the health of the graft. While not common, there has been described later deterioration of immune function with frequent infections or declining number and diversity of the T cells, or conversely, difficulty with declining antibody production or ability to maintain a specific response to vaccines. And so assessing both T and B cell immune reconstitution is quite important and is able to be done through most commercially available labs. The other thing that we've really tried to emphasize, and the list was too long to include everything on this slide, is that it's also important for patients to have assessment of their engraftment, and not just the overall engraftment, but specifically looking at what does the T cell engraftment look like? What does the B cell engraftment look like? What does the myeloid chimeridge engraftment look like? Because we do have data, again, through work done by the PIDTC, that having good myeloid engraftment will reflect itself and lead to greater T and B cell engraftment. And if you have patients where T cell counts are falling, the overall engraftment level may, if you don't do lineage specific, may still look quite good because the T cells will just decline. You're not going to have the patient's T cells come back because the problem was that they couldn't make the T cells to begin with. So if you do overall engraftment, you won't be able to see all the lineage specific changes. In terms of the non-immune late effects in monitoring, what it does seem is that in contrast to that first slide that I showed you, in patients who were transplanted for all different kinds of indications and predominantly for malignant indications, within the realm of our immunodeficient and our SCID patients, particularly, the things that we would want to be particularly aware of are assessment for growth. So we know that at a minimum, we want annual monitoring of height and weight, and then more frequent monitoring of that for patients who have a continued need for nutritional support or who are showing any evidence of slowed growth or falling percentiles on their growth curves. In thinking about these neuropsychologic effects, at a minimum, we want everyone to have routine, good pediatric care, making sure that we're following age-appropriate general pediatric guidelines for normal development and having a very low threshold for referral to supportive therapies, be it speech or PT or OT or cognitive play therapy. All of these things, when acted upon early, can have lasting benefit. We also want to make sure that we endeavor to have patients who are transplanted to SCID have at least one formal neurocognitive assessment once they're able to participate. Usually that's at about age 5. That can often be done through the local transplant center. But if not, sometimes schools are able to help with that because, about age 5 is when they would usually be able to have their first assessments for things like kindergarten. And again, if there's even subtle abnormalities in that formal neurocognitive assessment, we'd have a very low threshold to recommend for supportive therapies and to intervene sooner rather than later. The late pulmonary diseases that have been described are more common if patients had difficulty with infection, particularly pulmonary infection prior to transplant, or if they are on long-term IVIG. Patients who have need for long-term IVIG are at greater risk of having recurrent ear infections, sinus infections, and pulmonary infections. And so over time, that can lead to more risk of lung disease. We already talked about the risk of bone disease, in particular, poor linear growth. We have also seen some patients with difficulty with development of thyroid disease. Also, that is more commonly associated with the exposure to alkylator-based therapy, as is difficulty with gonadal dysfunction or infertility. That being said, I think it's also really important for patients and their families to realize that gonadal dysfunction and infertility are not 100%. And so as patients reach that age of puberty, making sure there is an endocrine assessment to make sure they're going through normal pubertal development and having appropriate counseling to the patient as they may be becoming sexually active, that they are, they will not know for sure that they could not potentially become pregnant or father a child. And so taking appropriate precautions to not have that happen if that's not their intention. Through the IDF, there have been some really nice tools that are available to help patients monitor their health. And then Be the Match, which is kind of the US group for helping to assist patients navigate the transplant world. That they also have after transplant guidelines for patients, and they have a mobile app that allows you to maintain your own personal data and be able to have it be portable as you go from one center to another. I think the advent of electronic medical records has made it much easier for our patients to feel comfortable with moving from one center to the next, so that they don't feel like they have to stay in one place when they are ready to move elsewhere, which I think is important, that people feel that they are free and able and should go and live happy, active, normal lives. I did want to touch also on the importance of genetics for clinically diagnosed patients with primary immunodeficiencies, including SCID, who may have already been treated with transplant. So as this group knows, there are well over 300, now there are closer to 500 genetically defined forms of primary immunodeficiency. And nearly a third of these are combined immunodeficiencies, which, depending on the severity of their onset and the timing of their onset, may present like a SCID patient. So we really would encourage that every effort should be tried to establish the genotype of SCID that a patient has, ideally before the transplant, especially if there's concern for radiosensitive SCID, because that ideally should influence the sort of conditioning that might be considered. That being said, if for some reason a genotype is not able to be established, either because the family wasn't ready to give consent for genetic testing, or the genetic testing was attempted, but there was no conclusive result found, it's really important to hold on to some pre-transplant DNA for further testing. As you can see in this graph, we are just experiencing a huge expansion in the number of diseases and able to be defined genetically. And so what might not have been picked up 5 years ago on a genetic panel for SCID or primary immunodeficiency would be now. And I would anticipate that that will just continue to grow in the years to come as we are able to sequence for more and more things, and more patients are able to have whole exome or whole genome testing on a research basis that then is able to be validated and proven to have caused an immune deficiency phenotype. But if there had not been pre-transplant DNA, so say you are a young adult patient or an adult patient who had a transplant done for severe combined immunodeficiency that was defined by having a lack of B cells, and there was a family history, or even if there wasn't a family history, it is still possible for genetic testing to be done for those patients today. We don't generally recommend to use saliva or cheek swabs in a transplanted patient because there can be some mixing of the immunologic cells, and so we don't know for sure that we'd be testing the gene of the patient versus the donor. But what you can do is, if you take a skin biopsy and grow up skin cells in a tissue culture, which many hospitals are able to do clinically now, you can then take the genetic material from the skin cell and use that for an assessment of what the patient's own genotype is. So it is never too late to be able to pursue a definitive genetic diagnosis for a patient with severe combined immunodeficiency or any other immunodeficiency, even after transplant. Also want to touch on the importance of genetic counseling. So this is a process. It needs to be an iterative process. And so while the genetic information can and really should be shared in the acute setting of preparing for transplant for a SCID-affected child, we as providers need to be very sensitive to the fact that this is a time when families have a lot of information coming at them. They have a lot of different concerns, and it's a very high stress period of time. And in addition, they just had a new baby. So there are all the just general stressors associated with a newborn, and then we've added this complexity of a devastating, life-threatening illness. And so it's really important that after the transplant process has been completed, the discussion of the genetics and the risk of reoccurrence within the family occurs in follow-up settings so that the families can continue to ask questions. I try to bring this up with my patients every year when they come for their follow-ups, just to kind of reiterate it. I just mention it. If they have questions, we talk about it, and then if there's no questions, we just move on. So it doesn't have to be a big, long process, but I think just refreshing it every time. And then separately from counseling the family, again, as children who were treated with hematopoietic stem cell transplant or gene therapy for that matter, approach adolescence and certainly later adolescence and their young adult years, spending time to specifically counsel the patients about their risk of having children who are either carriers or may be affected by severe combined immunodeficiency is also really important. The other thing that is not here, but I should have added as a point on the slide, is that it's also important to make sure that families are aware of the ability to have carrier testing done in siblings of the patient who is being treated, so that the whole family is being taken care of from a genetic counseling and genetic health approach. That's the end of my formal presentation. I thank you very much for your attention. I thank you for inviting me to speak with you today, and I'm happy to take any additional questions that you have. Thanks.
Thank you so much, Dr. Heimall. That was wonderful. We do have a couple questions coming through.
Sure thing. Happy to be here.
All right. So the first question, I have PI and an autoimmune disorder. I would like to have a full genome test done for research. I would also like a full genetic map done so I know my treatment options. How can I find a study or physician, and they prefer the West Coast?
So what I would say is I would talk to your current immunologist about, where locally accessible to you that would be available. What I can also say is that the Modell Foundation does have a genetic testing program available for families and patients who might be limited by their insurance or other resources, but that is not whole genome or whole exome-based testing. That is a panel-based testing done through a commercial lab. And there are several other commercial entities who will support genetic testing for PI. And so I think the best thing to do is to have this conversation with your local immunologist who's helping you with your symptoms and your PI, and ask them what next steps they would recommend to pursue genetic testing. The whole genome testing currently is still only available on a research basis, but there's whole exome testing available through various different commercial labs at this point.
All right, wonderful. Well, it looks like that was our only question from the audience. So thank you for submitting your question. We again want to thank Dr. Heimall for volunteering her time today. This was a wonderful presentation. Thank you so much.
Take care. Have a great weekend, everyone. Bye-bye.